Hello, everybody. My name is RBROE, DNP. I am going to be talking about adult health urology. This is a topic that's been a passion of mine because at some point, and maybe it's something that's happened in your life, someone experienced some sort of urological issue. And because it's part of elimination, and because most of the time humans, when they're dealing with elimination, require a lot of privacy, it causes a lot of shame and embarrassment when in normality it's lost to aging or disease. So I want everybody to think that this information can truly help you as a new nurse, because you have to understand that stigma and shame and pain and suffering that people experience from an empathic point of view as we cover the system. Because at some point in time, as we age ourselves, we're going to be dealing with some of these same issues. So in the treatment world, so much technology has come about in the recent years to improve the quality of life for so many people in the world that it is an amazing specialty to be involved with, especially for urology here. Urology is on the cutting edge, literally and figuratively. And if you are from the South, we have a lot of kidney stone issues in the South. They call it the Stone Belt. And you'll see many urology patients in this area. So there may be other areas in the country where this is the case, but we tend to see a good many renal and kidney stone patients in the South, but also other kidney issues as well. And we're going to talk about that a little bit of trivia as we mosey through this material today. So hang in there. We have lots to cover. Our objectives today are to recall the basic anatomy and concepts of elimination that involve the urinary system, explain how those physiologic changes in the urinary system affect elimination when caring for the adult patient, review some common problems in the lower urinary tract, that means below the kidney, and examine diagnostic and procedural advances in treating patients with renal and urinary health system problems related to the bladder and prostate. And then we're going to discuss some urinary catheterization issues and evidence-based practice regarding urocatheter associated urinary tract infections. So as biological females and males share some anatomical structures, we also have some differences. Both sexes have kidneys, adrenal glands, bladders, ureters, and urethras for the most part. Males only have prostates, testes, and external genitalia, penises, which is the main reason why the male has a much longer urethra than the female. Females have additional internal organs, such as the uterus, the fallopian tubes, and ovaries, that can lead to additional challenges within the urinary system based on space and childbearing status. And as you know, when women become pregnant, that uterus starts crowding out some of the other organs and pushing pressure on those organ systems, the bladder being one of those. Other organ systems interrelate with urinary and renal systems due to the location and hormonal influence, environment, and diseases that a person may experience in their lifetime. So as you see the differences between the male and the female, and the difference between the length and that urethra is the big change in that, and the fact that the male has a prostate, the female does not. So normal elimination of urine depends on many things, but the biggest part is trying to maintain that homeostasis. And when you start thinking about endocrine systems and the hormonal systems in our body, that is the main goal of the pituitary gland and the hypothalamus and all that, is to maintain that homeostasis. And it's very difficult, especially as you age or develop physical disorders, have trauma or disease. And so when we talk about the urinary system, we're referring to that process of elimination of urine from the body. And that normal elimination of urine depends on at least 5 things. And we'll talk about that here, because that CNS system has to do with a lot of hormonal control. Adequate nutrition is the number 1, which includes that high fiber, the fruits, vegetables, and whole grains. Your adequate hydration has to do with the amount of water that you consume per day. And water's in lots of things, but the main thing that we want to talk about is consuming actual plain water, and that's 8 to 12 glasses of water per day, unless there's some kind of medical reason that's restricting fluid intake, like heart failure, and their reduction of the amount of fluid that they could take in per day. But having a hydrated person and body is extremely important in making sure that that urine is dilute enough to go through the filtration system of the kidneys. Adequate muscle strength is pivotal to controlling mobility, to getting just pragmatically to get to and from a bathroom or be able to sit or stand. It is also important for the pelvic floor to strengthen and control the movement of the sphincters in the bowel and the bladder, because both of those systems have sphincters, and that is related to whether you can control it enough or if you're going to have incontinence or lose control of those two systems. A healthy central nervous system controls nerves that control the sympathetic and parasympathetic nerves. And your sympathetic, of course, is your fight or flight. Your parasympathetic is your basal nerve system that goes along all the time. Like if you imagine why your heart is beating and why you're breathing while you're sleeping, that's your parasympathetic. It also determines how well all autonomic or fight or flight responses work. And so your bladder is surrounded by nerve endings, and those nerve endings work to help you eliminate the urine if your bladder gets too full. Finally, freedom from infection is important, and if any of our immune responses falter, we become susceptible to infection within the elimination systems as well. So if you're prone to get urinary tract infections, that can be problematic on kidneys as it moves backwards into the kidneys and causes problems with blockages. And just makes you sick overall, and you get septic. So how does the bladder work? Well, the bladder fills during the day with whatever we eat or drink. That fluid is exhumed out of the food and the fluids that we intake, and that rate of filling depends on the fluid intake that we take in every day. And the nerve signals are sent to the brain to let you know when it's time to urinate. And usually when you see that bladder diagram there, your detrusor muscle starts letting you know when it's about 3/4 full. It is time to urinate. And so to urinate, other nerve signals contract the bladder and relax the urethral and pelvic floor muscles. So it's like squeezing down from the top and causing that bladder wall to contract in, and those sphincter muscles relax to allow the urine to escape the bladder. The urinary problems that are mostly below the kidneys are listed here, and those consist of incontinence, cystitis, urolithiasis, benign prostatic hyperplasia, otherwise known as BPH, and bladder cancer. So we're going to go over those today, and we're also going to discuss some treatments that are available for each of those problems. One of the most significant things as a nurse are the main reasons patients seek care for a majority of urine problems. Most of the time, patients stay home and take care of things themselves, but they don't call the doctor until they start having significant symptoms. And it's usually a couple things, but the number one thing that drives patients to get on the phone or drive to an emergent care center is hematuria or blood in the urine. Can't always tell about the color alone. If someone like me enjoys eating beets, your urine can turn red just from the beets. But it's not that. You have to look at you have to do an actual blood test to find out if there is blood in the urine itself. So that's why most people go to the doctor, is blood in the urine. Changes in the renal system occur with aging. Can't do anything about it. When you hit about 65 years of age, your glomerular filtration rate is about half the rate of a young adult. And that's the speed at which the urine filters through the kidneys. At nighttime, you start waking up more than once at night to urinate, and that is because your bladder becomes a little bit smaller and able to gets thicker, and the walls thicken, and you actually have less ability to hold urine in as you get older. Urinary retention, the urine stays in the bladder and is not fully emptied, Sometimes in speed trying to empty the bladder, people do not completely empty the bladder, or they may have some central nervous system issues that would cause them to have to squeeze on their bladder to completely finish the urination, or they have some sphincter control problems. Or they may have had some kind of spinal stenosis or spinal disease that would cause them to have problems with nerves that are related to the urinary retention. So chronic conditions like diabetes, heart failure, kidney disease, sleep disorders, overactive bladder, urinary tract infections, and large prostates can cause urinary frequency and make people get up at night. And then you can also have caffeine and alcohol that can increase that production of urine. And then you can also have diuretics that are drugs that are supposed to allow you to urinate more that can cause you to get up more. Your urinary retention can be from a variety of things. In men, one of the most common things over the age of 40 is that prostatic enlargement, or BPH. This is an enlarged prostate. That's an overgrowth of tissue that can restrict the urine flow because it puts pressure around the urethra. So the actual tube that urine flows through is somewhat restricted. There can be strictures from scar tissue in the urethra that cause the passage to narrow and restrict urine flow, and this could be from passing kidney stones over the years. Pelvic floor weakness from the uterine or bladder prolapse can partially obstruct the urine flow. And yes, gravity takes its toll on all of those internal female organs, and you can have a bladder prolapse and you can have a uterine prolapse, especially after childbirth. Kidney stones in the urinary tract can block the flow of urine. That's pragmatic sense. If you're going to have a stone in there, it's going to block it. Tumors can also obstruct the urine flow. Constipation or fecal impaction can cause pressure, which can obstruct the flow of urine. Because as your bowels swell to try and push that rectum or to release that final plug of feces, it'll start swelling. And so as your abdomen swells, it puts pressure on the urethra as well, and bladder. Neurological problems, paralysis can damage nerves to the bladder, and the bladder cannot get the proper signals from those nerves. It can also happen from spinal stenosis or some kind of neuropathy caused by your diabetes, multiple sclerosis, strokes, or traumatic injury to your vertebrae. Urinary tract infections or inflammation can lead to difficulty emptying the bladder, and immobility can weaken the bladder muscle, and if you don't move around, you're going to lose that muscle tone. And finally, medications can lead to urinary retention. Some of these can be your anticholinergics, your opioids, and some antidepressants can cause a lot of urinary retention in patients. So this is not just sequestered in the United States. People all over the world are affected by urinary incontinence. Women are more affected than men, and the reason why that may be could be diabetes, stroke, impaired mobility, cognition, increase the chances of that impaired mobility or cognition can increase the chances of that problem with incontinence. They just don't want to go to the bathroom, or they forget to go to the bathroom and wait too long to go, and they end up being incontinent. It can also occur in women that when they deliver their first child after the age of 30 by vaginal delivery. They can have pelvic prolapse, prostate problems in men, heart failure, obesity, nerve injury, and CNS conditions like dementia, Parkinson's. Paralysis also increase the prevalence and incidence of incontinence. It's a constant challenge to keep our older adults clean and dry, especially those in long-term care. You see that a lot. They're starting to use things outside of a urinary catheter. The inpatient guidelines for catheterization are we do not use catheters just for convenience sake. We need to get patients up and moving to the best of our ability. There has to be a dedicated reason to have a urinary catheter in patients. One complication of incontinence can be skin problems from exposure to moisture that can develop on the skin due to heat and sweat. and from those protective pads and the urine. And so they have to have some kind of exposure to air from time to time. And the main goal is to keep that skin clean and dry. And the use of those liners and pads and bed pads and disposable pads is important, but they need to be changed. If it doesn't occur, skin breakdown can occur, leading to ulcerations and associated wounds, pressure wounds, and from maceration from the moisture. And nursing care planning always has to address tissue integrity and assessing that skin, including perineal areas for cleanliness and skin condition. And when you're dealing with prevalence of injuries or infections, the second most common cause of incontinence is urinary tract infection, just from the urgency and the inability to fully empty the bladder. So let's talk a little bit more about what it is to have incontinence, and because so many people suffer from it. It's the loss of bladder control with involuntary leakage of urine. It's more prevalent in females, again, as we stated earlier, because it increases with age. It can be treated, and depending on the reason for the incontinence, it's often curable, but you got to know the symptoms, and you have to know where to start. So the most common causes of urinary incontinence are stress incontinence, urge incontinence, overflow incontinence, and functional incontinence. And these are how they define incontinence in your medical records. You'll see that. Stress incontinence can be overcome with your pelvic floor exercises, behavioral modification, and urethropexy, where they go in surgically lift up the bladder. Your urge incontinence has to do with urgency and feeling like you need to go to the bathroom. And that's a lot to do with inflammation. So they'll do a lot with anticholinergics and with your NSAIDs. Your overflow incontinence has to do with not being able to tell if you're full or not. So a lot of times you have to make sure that people will go in there and go to the restroom if they are ambulatory, and just if they've lost their feeling or have neuropathy or have diabetes or one of these diseases like MS or Parkinson's, you got to make sure that you're rounding on your patients inpatient wise and get them up and go to the bathroom or use a urinal or a bedside commode. Some of the treatment modalities for that are cholinergics, alpha adrenergic blockers, because that will somewhat decrease the amount of urine. Functional incontinence has to do with just the ability to ambulate or get to and from a bathroom. And so it could be eyesight problems, mobility problems. They're immediately post-op, so they can't get out of bed and they're woozy from medication, or they've been given pain medication. Access to the bathroom is too far away, and that kind of thing. Lighting in the house may be bad. So the functional incontinence may just be that they waited too long, or they just can't see well enough to get to and from. Key things that you have to remember to do to maintain that urinary incontinence and manage it is to maintain the hydration. Limit your alcohol and your caffeine and artificial sweeteners. All of those things stimulate the bladder. And then to urinate at regular intervals during the day. So like I said, if you've got someone who has Parkinson's or MS or something like that, they should go to the bathroom quite a lot and make sure that they're emptying their bladder, especially before bedtime. And not drink anything before they go to bed. And a lot of people like to have that liquid right by their bed, but if they do, they're going to know they need to get up. So that means that they're going to have access to a bathroom close by, and they're going to have access to good lighting that stays on all night so that they can see where they're walking. They may need to have assistive devices like a walker to help them get to the bathroom. The high fiber diet to eliminate constipation or fecal impaction. I'm sure you're wondering why high fiber diet would be part of this discussion. But as you realize in this lecture, constipation leads to a lot of retention of urine, and it can cause problems with that overflow incontinence if you don't feel like you're going. So just maintain that high fiber diet to eliminate that constipation or having a fecal impaction. So the two things with hydration and the fiber will help eliminate some of that. Also, they can take stool softeners, things of that nature that will help with that as well. Bladder training programs and pelvic floor exercises are some of the things that can be done to help from a physical therapy standpoint, and they can use behavioral health therapy to get your mind set to relax. A lot of people don't urinate in public. They don't like to urinate outside of their home, and so having some mindfulness meditation, some yoga, some of those things can help. Magnesium can help with the muscle strength, and your apple cider vinegar can also help with some of the acid-base balance in the urine. So cystitis, we'll talk about that now. That is inflammation of the bladder. And remember that UTI can be a cystitis, but cystitis is not always a UTI. So chronic interstitial cystitis is that feeling of pain and pressure in the bladder that lasts longer than 6 weeks without having an infection or any other clear-cut cause. So non-infectious cystitis can occur from chemical agents, oral, liquid, topically, through direct contact. It could be chemotherapy, could be spermicidal jelly used for contraception, soaps, bubble baths, and dyes. Those things can cause non-infectious cystitis. Drug-induced cystitis could be chronic use of certain drugs that can cause cystitis, like ketamine, your NSAIDs, penicillin, your mitomycin C, which is a chemotherapeutic agent, and some immune checkpoint inhibitors used in cancer immune therapy. Your radiation cystitis is a type of cystitis that is a complication of pelvic radiotherapy for pelvic cancers. It can range from mild irritation to life-threatening hemorrhagic cystitis. And if you see in the slide below, you can see where there is a normal bladder wall, and then you see the cystitis picture, which shows a very angry and red bladder wall. The foreign body cystitis, this type of cystitis is caused from frequent catheterizations of the bladder. These devices can carry bacteria into the bladder, causing current UTIs and including culminating in chronic inflammation. So when we look at the difference between the two types, acute and chronic cystitis, one is infected related, that's acute. It occurs suddenly, it's due to germs or bacteria, and it's limited in its duration. Whereas the chronic or interstitial occurs over time. It's not related to infection. It's due to drugs, chemical agents, foreign bodies, radiation, and diseases. And its symptoms last greater than 6 weeks. And the way that you determine what kind of cystitis a person has is through physical exam, urine culture, and an ultrasound of the bladder, or a CT scan of the bladder or the abdomen. Remember, there are some patients that require frequent catheterization. And one of those things that you would want to be aware of is some of the diseases that might cause cystitis. Endometriosis is one of those, pelvic inflammatory disease, lupus, and other autoimmune diseases. They put deposits on the bladder wall, which causes an inflammatory process. Crohn's disease, that inflammatory process can cross into the bladder and form connections called fistulas. Diverticulitis can do the same thing. We can form those connections called fistulas. And then tuberculosis can travel from the kidney to the bladder, causing inflammation and scarring of the bladder wall. The symptoms in the female can fluctuate with the menstrual cycle, and the pain may occur in the vulva or vagina. Pain can also occur across the abdomen or into the back, and this may worsen with an empty bladder, which is kind of a telltale sign, because you would think that after emptying the bladder, it would feel better, but not in a cystitis case. Cystitis is also more common in older men, and this is primarily because of the prostate enlargement, which usually starts around 45 to 50 years of age, and then it starts enlarging more and more every decade. And that enlargement can block the flow of urine from the bladder as it compresses the urethra. Symptoms of cystitis without infection are pain in the abdomen, back, and genital areas, pain during sex, fatigue, low-grade fever, burning during urination, hematuria, nocturia, incontinence, strong or foul-smelling urine, and in older adults you may even see confusion and delirium with acute change in mentation. If you don't do anything about cystitis, it can cause the kidneys to be infected as well. And this will get into a more septic type of symptomatology with nausea, vomiting, high fevers like 103, 104, upper back and flank pain. There may be some purulent or clear drainage from the penis for men, pressure or pain between the anus and scrotal area, and pain in the penis, scrotum, rectum, and testicles. There is no single diagnostic test for interstitial cystitis. As I stated earlier, many of the symptoms listed are similar to other urinary tract disorders, so making a diagnosis is a challenge. So when patients are delayed seeking care, it becomes more urgent, and it also results in infectious processes adding to the chronic bladder status. So you have to take a urine culture, do that ultrasound and cystoscopy possibly to help differentiate between the various urinary tract problems. So we've determined that there is the harshest infection by our urine culture and sensitivity. And when we talk about what the sensitivity part of culture and sensitivity means, the lab takes that culture and the specimen, and they determine the organism and the bacterial growth. They then test that microorganism against different antibiotics to see which ones will be effective in killing it or stopping the growth of that bacteria. And from that information, the doctors can then select the most appropriate antibiotic to treat the infection. And that's why they do a culture and sensitivity. That organism will either be sensitive, where it can kill or stop the growth of that bacteria, resistant, where it does not kill or stop the growth, or intermediate, where it has some effect but may not be strong enough to effectively kill the organism in toto. So one of the most common and problematic issues, though, is that current UTIs, because you're constantly giving people antibiotics over time. Eventually, you're going to develop a resistance to that antibiotic where you'll have to go to different ones and try different ones. And a UTI can occur anywhere in the urinary tract. It doesn't have to just be in the bladder. It can be anywhere from the kidney to the urethra. An infection of that urethra is going to be what they call urethritis, and this can cause burning sensation when urinating, cause cloudy discharge. Bladder infection or cystitis may result in that pelvic pain, frequent mild urination, blood and urine. A kidney infection or acute pyelonephritis may cause back pain, specifically on the side of the affected kidney. You can have high fever, severe chills, shaking chills, we call that rigors, and nausea. And when it gets to that case, you really, really need to see the doctor. UTIs typically occur when bacteria enter the urinary tract through the urethra and multiply in the bladder. These bacteria come from the digestive tract through fecal material. Escherichia coli or E. coli is usually about 80% of what causes urinary tract infection, followed by Klebsiella pneumoniae, Proteus mirabilis, Enterococcus faecalis, and Staphylococcus Viticus. And other bacteria can be brought over with skin or sexual contact. So women who use certain types of birth control, such as diaphragms or spermicidal agents, are more at risk for this. The hormonal deficiency during menopause also make women more vulnerable to infection. So one of the big recommendations is to make sure if you're going to be using diaphragms for your contraception, make sure that you clean them well after each bout of intercourse. And immediately after intercourse, get up, take that diaphragm out, and clean and urinate. So as you know, E. coli resides in the GI tract and it's harmless there, but when it gets outside of that bowel area, it can cause a real problem. It can adhere to the urinary tract lining and proliferate and cause infection. So UTIs are usually from that fecal contamination, especially in women because of the shorter urethra distance and proximity to the anus. So hygiene is key, along with the adage to wipe from front to back. Klebsiella is a problem, particularly in hospital-acquired infection. It's also more often found as normal flora in the gut, but it's also found in the environment as well. It could be found in water. So it's been proven to be resistant in many commonly used antibiotics. So you just have to be careful with that. Proteus mirabilis is known for its ability to produce urease, which is an enzyme that breaks down urea in the urine. And that changes the pH in the urine to become more alkaline. And the increase in the pH can cause struvite crystal formation, leading to stones in the kidney, which cause even more complicated urinary tract infections. So people that have long-term catheters are particularly at risk for this organism, especially when they migrate to the infection migrates to the kidney, causing pyelonephritis. That's where you get into your severe septic symptoms. The Enterococcus facialis is gram-positive bacteria that's part of normal flora. It is linked to healthcare settings and catheter use. It is resistant and can persist in harsh conditions and is resistant to multiple antibiotics. So the people that have multiple comorbidities are at highest risk for this particular organism. The Staphylococcus saprophyticus is a common cause of UTIs in young sexually active women. It's not as popular as E. coli, but it is a problem in this age group. So when you look at this demographic, this one probably is right up with the E. coli in probability. It's known for its strong adherence to the uroepithelium, and it allows it to colonize to the urinary tract and cause infection. It's susceptible to a wide range of antibiotics, however, but it's important to know the cause of the UTI and educate women on the proper preventative measures, hygiene after sex, and proper treatment timing. And in this slide, you can see how that bacteria can actually cause the wall of the bladder to thicken and get inflamed. And you can see all the different organisms down there. So in the early stages of a lower urinary tract infection, you may feel sudden urges to void with a squeezing pain, like you haven't quite completely emptied your bladder. Frequent urges to void, pressure in your abdomen or lower back. Your urine can turn cloudy. It may contain some blood. It may or may not smell good. It could smell very strong or very fishy smelling. As the infection progresses, you may get a fever, chills, and pain in the flank, nausea, vomiting, fatigue. Seniors can get very confused and delirious, which is usually a #1 sign, especially in females, of a UTI. So when you see a sudden behavioral change in a senior female, you can suspect an undiagnosed UTI and they need to get to the doctor. Your phenazopyridine hydrochloride is used to relieve pain, burning, and spasms caused by infection. It's not going to kill the infection. This urine may turn a red, orange, or brown. You may get a headache from it. This is really to tide you over for a couple days in case the doctor's out. But you probably, here you get a urinary infection on Friday, your doctor's out, and you don't want to go to emergent care. You want to go specifically to your doctor. Then what's going to happen is you're going to have to do something to tie yourself over because it's very uncomfortable. So you get azo, and it gives you a couple days to tie over. You also have not cured anything. You've just given yourself that temporary relief. So the things to do in the meantime is to hydrate well, limit your alcohol, and limit cannabis use also. Methanamine and sodium salicylate is a over-the-counter preparation called Cystex. This is a combination of an antibacterial agent that helps control the growth of the bacteria in the urinary tract, and it also has an analgesic that provides pain relief. This is not a cure, but once again, it's a stopgap measure until you can get to the provider. Drink plenty of fluids, flush out that bacteria more frequently, wipe from front to back after a bowel movement. If you have any wipes, I would recommend using those wipes after you go to the bathroom, front to back. This helps prevent bacteria in the stool from spreading to the urethra. And this is helpful, especially after any bowel movement, is to use some kind of cleansing wipe. Empty the bladder soon after intercourse to flush bacteria. And I know this is very strange to say, but when you get up after intercourse, go straight to the bathroom and go to the bladder. Empty your bladder. Avoid douches and powders because they just do nothing but harm the irritation. They harm and irritate the urethra and the interior of the bladder. And the diaphragms and spermicides for birth control measures, they're fine to use, but you need to make sure that you clean them properly and you take them out and clean them properly. There are some foods that can help relieve symptoms. Some are researched, some are not. From a dietary standpoint, cinnamon, cranberries, probiotics, diuretic plant-based foods, or like asparagus, they act as somewhat of, the asparagus acts somewhat as a diuretic. And some herbs like birch, couchgrass, and horsetail, they have been touted to help relieve cystitis in urinary tract infection or kidney infections, but there needs to be more research on those. You can certainly try them to see if they help you, but if you have any allergies, you need to discuss this and tell patients to discuss any kind of herbal preparations with their doctor before they start taking them, because there can be some, I know I think maybe in birch there is some salicylates content in birch, and so I believe that something like root beer, things of that nature, they kind of make with birch bark. So if you have an allergy to salicylates, you might want to be careful with that, and make sure that you talk to your doctor before you start taking any herb preparations in addition to your prescription drugs. And there may be some interactions there you need to be careful with. If you're already taking high diuretics, if these drugs have diuretic properties, you may lose too much urine and become severely dehydrated. So you have to be careful with, just because someone says it's an herb and it's safe and all that, you don't know exactly until you study your entire health history and with your doctor and understand what's safe and what's not. Some foods to avoid or limit are tomatoes, high acid foods, caffeine, chocolate, alcohol, and citrus beverages. If you are prone to UTIs or cystitis flare-ups, if you take long car trips, or you're a truck driver, for example, or you take some scheduled breaks to empty your bladder, and you have to pull over every once in a while and get up and go to the bathroom. Tight clothing can put pressure on the urethra, so wear looser fitting clothing, and by all means, stop smoking. And there is a educational video here from the Sepsis Alliance that talks about when urinary tract infections turn deadly and what to do. But we've covered the majority of those things, but it's interesting to see what the Sepsis Alliance says. The other thing I want to mention here is the telemedicine. If you can't get to an urgent care, or say you have a very high fever and you don't feel like getting out, a telemedicine situation might be an option for you. till you can get on your feet. But you really, if you're very, very sick, it's not, it's just, you're very, very ill, you need to just call your doctor to get some prescriptions or antibiotics or something. Most doctors will give you something, but they truly, really want a urine sample for culture and sensitivity to make sure that they're going to get the right drug that's going to kill this infection. If you're a male, urinary tract infections that cause prostatitis or inflammation from that prostate are very hard to eradicate. It takes lots and lots of antibiotics. So just be forewarned, for the male, it is a longer duration of infection control treatment. Cystoscope findings can reveal foreign bodies, that's a bladder perforations from C-sections or any other abdominal pelvic procedures requiring repair. Stones can be removed with retrieval baskets or with laser lithotripsy, which obliterates the stone and pulse energy. The cystoscope is an endoscopy procedure, but it's done with the patient under anesthesia, most of the time in hospital. They do cystos in doctor's offices, but they are not comfortable. Patients deal with them all the time, especially chronic urinary patients. And so they will definitely be used to having cystoscopies. Your bladder cancer patients are used to having follow-up cystoscopies. And so a lot of times those cystoscopies are done in the office. Calcium stones are the most prevalent. Uric acid from excess uric acid in the urine. It's a normal waste product. Struvite is associated with UTIs and made of magnesium, ammonium, and phosphates. And cystine stones are rarely seen, but they are a form of a genetic condition called cystinuria, where the body excretes amino acid cysteine into the urine. And this is the rarest stone. It is a xanthine stone, which is also associated with genetic conditions or medications. So the cystoscopy can do a lot of things. It can actually flush out your bladder. It can assess your ureters. You can shoot some contrast dye into the ureters to see if there's a blockage or a stone blockage. So you're looking at whether you can see a healthy bladder, any polyps in the bladder, or if there are any stones. Patients who experience the nephrolithiasis or kidney stones may have genetic and environmental factors that contribute to forming stones. Usually once a person has started developing stones, they're more likely than one who has never to develop other stones in their lifetime. So it could be multiple stones in their life. So knowing the analysis of that stone helps providers assist patients with ways to prevent further stone formation. The cystoscopy is also a gateway procedure for other procedures like prostate resection for enlarged prostate, for removal of other bladder tumors, for growths that at the time of the procedure is not yet known if the growth is cancerous or not. So this is a diagnostic procedure for that. Also, under a cystoscopy, the urge incontinence can be treated with Botox injections into the detrusor muscle in about 10 to 30 sites during one session, and it will last about 6 to 9 months. So what it does is it relaxes the muscle and relieves the urge to urinate, and this will affect temporary urinary retention, which may require self-catheterization intermittently. So it can actually cause that. So you have to warn your patient that if you get Botox in the bladder injection, you may have some retention problems that you have to address. So when we're looking at why the urologist would use cystoscopy to check your bladder, these are the reasons. You have trauma, obstruction, bleeding, dysuria. You could have infection, disease, or obstruction that needs to be diagnosed. You have recurrent tumors, blockages, infection, bleeding, or you're having incontinence problems. So this really is a procedure to help diagnose and identify what is causing the patient issues. So the doctor's looking for that trauma, obstruction, or bleeding. This could be a bladder perforation, obstruction by a large stone, or bleeding from the bladder cancer tumor, or other inflammatory process. Obstructions that cause problems can be loculated behind an obstruction or a dammed up stone. And once that obstruction is removed, you can expect to see some pus drainage or purulence that's going to exit around the area of the blockage. And when you see that, expect that that patient is going to have a shower of that bacteria into their bloodstream, and they may have flu-like symptoms with fever and shaking chills after the procedure is completed. So any blockage is an emergency, especially if you have blockage of urine that can't flow out. Infection can be walled off behind that stone. Be prepared for treating for sepsis when infection is released. And when you're treating for sepsis, that means you're going to be giving lots of fluids. You're going to be giving some kind of antipyretic or analgesic for pain. Sepsis is not pain-free because you have acidosis building up in the cells. Stone fragments that are removed can be sent for analysis. The antibiotics are given before and after. They usually give a broad spectrum antibiotic until they get that culture and sensitivity back. And when they get that sensitivity back, then they will prescribe the appropriate antibiotic and the proper dosage. Your hydration is key for maintaining that proper hemodynamics, and your pain management, temperature control. Patient may have a stent placed and a catheter placed. So if the urethra is too swollen or damaged from that stone, or even the calyces of that kidney has a stone in it, it may irritate that kidney and cause swelling, which may cause you to need to have that catheter or need you to have that stent placed so that it doesn't swell and occlude itself. So when stones migrate to the lower urinary tract, the treatment is going to be laser lithotripsy, where they use the laser to actually touch the stone and obliterate it. This percutaneous nephrolithotomy, or an ESWAL, where they can go in there and just blast the stone with sound waves. There is a limit to the amount of sound waves that you can put on the kidney. You can't just keep punching it, and that's what it feels like, or else you'll damage the kidney. So you have a limit on how many shocks that you can send to the kidney to remove that stone. Your cystoscopy and your ureteroscopy will help you get that stone out. You'll go up there with a basket and a fine retriever and eliminate that stone as far as it's broken up into smaller pieces that you can actually handle. So the stones can be removed with those retrieval baskets or with laser lithotripsy. A laser obliterates the stone with pulse energy and breaks it up into pieces that you can pass through your bladder. Stones are sent to the lab for analysis, and we talked about what those can be made from. The calcium stones are the most prevalent, for your knowledge. And these are pictures of the stones and what they look like. And anytime you have calcified stones, they will really show up on your x-rays. You can actually have stone formation from calcium in other places of your body as well. So it's not just in the kidneys and not just in the ureter or not just in the bladder. You can actually have stones in your lungs as well.